Hello, this is Dr. Omar Yassir, ophthalmologist from Syria. I have no financial disclosure, and I will be talking about pars plana vitrectomy for the treatment of endophthalmitis. Starting with the developments in surgical equipment and techniques, microincision vitrectomy surgery is conducted with 23 and 25 gauge instruments. Now we have improved visualization through wide-angle viewing systems and more experienced surgeons. Small gauge surgery obviates the need for peritomy and it's often sutureless. This results in reduced surgical times. When compared to 20 gauge surgery, it's argued that microincision vitrectomy surgery results in reduced intraoperative trauma and fewer complications, such as so-called port tears and subsequent retinal detachments, reduced postoperative inflammation, and faster postoperative visual recovery. Advances in surgical techniques have meant that pars plana vitrectomy in the context of endophthalmitis frequently involves induction of posterior vitreous detachment and greater than 50% clearance of vitreous. It's argued that there is therefore greater reduction of bacterial load and greater clearance of toxins and inflammatory debris. Recent studies have suggested that early pars plana vitrectomy in the context of endophthalmitis may even reduce the incidence of retinal detachment. The advantages of pars plana vitrectomy are reduction of infecting organisms, toxins, inflammatory materials, and opacities. It allows a more robust collection of samples for culture. On the other hand, the disadvantages of intraocular antibiotics are short duration of action, corneal opacification, vascular shutdown, retinal toxicity, and retinal necrosis. The endophthalmitis vitrectomy study, EVS, was published in 1995. The EVS is the only randomized controlled trial to compare medical and surgical management in acute postoperative endophthalmitis. The primary outcome was best-corrected visual acuity, BCVA, and clinical assessment of media clarity at 9 months. It concluded that immediate pars plana vitrectomy, less than 6 hours of presentation, improved visual outcome in patients who presented with perception of light vision, with 3 times the likelihood of final vision of 6/12 or better. In diabetic patients, post-hoc analysis found vitrectomy beneficial even if vision was better than LB at presentation. 10 years after, are findings of the EVS still relevant today? Cohen and Genie reported excellent outcomes for early complete pars plana vitrectomy in endophthalmitis. In a recent survey in 2018, Trends in Treatment Strategies for Suspected Bacterial Endophthalmitis, the majority of vitreoretinal surgeons perform pars plana vitrectomy if there is a clinical worsening within 48 hours following tap and injection of antibiotics. A recent retrospective study by Sridhar et al. Of 70 patients undergoing early pars plana vitrectomy for acute postoperative endophthalmitis found evidence for a reduced likelihood of evisceration or enucleation in Streptococcus endophthalmitis. The authors argued that there might be an anatomically protective benefits of pars plana vitrectomy that prevents either phthisis or panophthalmitis from developing. A recent retrospective study by Hu et al. Of 64 consecutive patients who underwent pars plana vitrectomy within 72 hours of presentation with acute onset infectious endophthalmitis, secondary to a mixture of cataract surgery, intravitreal injections, glaucoma filtration surgery, endogenous endophthalmitis, and trauma, found significant visual gains in patients who presented with hand movement vision or worse. Take-home messages. Microincision vitrectomy surgery results in reduced intraoperative trauma and fewer complications, reduced postoperative inflammation, and faster postoperative visual recovery. Immediate vitrectomy is recommended for the most severe infections, especially when an experienced vitreoretinal surgeon is available. Thank you.